with mechanics.
Next up is mechanics. Just 5 minutes.
So we'll start, we're going to break mechanics into 2 parts. The literature supporting what we do with these appliances, and then what to do with the appliances. So what's the evidence for expansion? Well, we know it actually can improve oxygen saturation. We know that if we time it right, before the skeletal form matures, we can get an outcome. We know that if we use expansion at the right time, we can improve not only transverse, but AP. So McNamara is the head of a major teaching university, Michigan, orthodontic department. And he spent 40 years studying expanding in the primary and the mixed dentition. And he's recommending we start early. Why removable? We know it works. There's randomized controlled trials that tell us removable appliances work. We know that they're just as good as fixed appliances. And they're no more uncomfortable than fixed appliances. We know that if we start around 6, we can get an incredible change by 8. We know that if it's used correctly, we can correct crossing of the bite, we can make things look better, we can improve the speech. We know that if we use primary molars as anchorage for retention, that we get really nice outcomes. We know that we get much better outcomes if we clasp the E's than if we clasp the 6s. Like, I'm not making it up. It's a randomized controlled trial. We don't have negative side effects on the permanent teeth if we use the primary teeth. Randomized controlled trial in the angle orthodontist. It unravels the front of the mouth if we anchor it on the E's, because it's closer to the front of the mouth. Why do we widen? To fit the front teeth in, dude and dudettes. It's all about width is about front teeth. So it's important to understand that I've broken it up into a protocol that's evidence-based, that is used at major teaching universities around the world. We had a question. Well, how wide do you go? Do you go until you can't go any further? Like, do we let the technician put the screw randomly in, because they come in 8 mil, 10 mil, and 12 mil, and then we just crank it until we can't crank anymore? Is it Enrico's job to guide us to how wide we should go? The answer is no. It's normal width for 6-year-old molars, measured at the gingival margin, just underneath the Carabelli's cusp, is about 38, 39 millimeters. All right? In Asians, it's close to the 40 because we got big, fat front teeth. Am I making this up? Well, no. People have actually studied what's normal. 37.4. If it's less, you get crowding, because width is about fitting front teeth in. And if you're too narrow, your front teeth don't fit. So we've been studying this for 5 decades because people are actually interested in doing stuff that's evidence-based. Banker in 2016 worked out that if you're more than 37.45 millimeters, your front teeth will fit nicely. If you're less than 34.92 millimeters, your front teeth have nowhere to go. And she measured gingival margin, Carabelli's cusp, and Carabelli's cusp. Now, do we just turn, like, just keep turning on one day and get it out as wide as we can? Well, that's what the surgeons do, right? They split the suture and then they crank until there's a whopping great big gap between the front teeth, and then they send the patient home. But we're not splitting the suture. We want to stimulate growth. So we use a semi-rapid expansion. Right? You need to know the screw that you're using. Now, we're told it's a 1 mil screw. Who's heard of that? Right? 1 mil per 360-degree turn. There's not one screw on this planet that is a 1 mil screw. You know that, right? There isn't one screw made on this planet since screws were made that is a 1 mil screw. They're all between 0.8 and 0.9 mils. Okay, so people talk BS all the time. All you got to do is open up the catalog for the manufacturer and have a look, and it says 0.8 millimeters, 360 degrees. Now do your due diligence. Don't believe a word that I say. Read the research that I've provided. Half a turn for the mums, 45-degree turn for the dads. Okay, for some reason, it doesn't cross boundaries of understanding. We want 1/8 of a millimeter, because the periodontal ligament is going to get squashed if you go any more. Why did we pick semi-rapid? Because we just want to be different? Do we just want to be different because we don't want to be in with the rest of the crowd? Because a lot of people teach stuff that's different just so that they stand out from the rest of the crowd. Well, no, actually, John Muir worked out semi-rapid expansion works really, really well. And so did Hoxler in 2018 when he was studying sleep and how semi-rapid expansion helps with sleep disorder breathing. So orthodontists don't like semi-rapid because they don't care about sleep disorder breathing. So you decide if you just want to do ortho or whether you care about sleep and breathing. Now, rapid expansion. We all know rapid expansion, but guess what? It works pretty good the same. Even if it's just to uncrowd teeth. We're not talking about sleep disorder breathing. We're just talking about ortho now. And semi-rapid works fine. And the difference is you're not breaking the bone. Because rapid expansion is about what? Breaking the bone, right? You're not happy until someone says, hey, there was one night where we heard a crack. Right? You know that the crack means you've split the suture, right? It's more stable, semi-rapid expansion. Angle Orthodontics, top tier review journal. The lower, we are not expanding the mandible. Don't ever say we're expanding the mandible, because we're not. There's no suture for us to stretch. What are we doing? We're expanding the mandibular arch. Level and aligning. Who knows what the curve of Wilson is? Well, it's the angulation of the molars. We're just uprighting. Ask any orthodontist, do you upright molars, like flatten the curve of Wilson and Spade? Yes, of course we do. That's part one of ortho, right? Level and align, mechanics, and then 18 months of unraveling all the adverse effects that you've put into it. That's all we're doing. It's not magic. It's not expanding the mandible. We're just working on alveolar bone. We're uprighting all the teeth. And our goal is to level and align. And you'd be surprised how broad everyone's mandibles really are at the basal level. Now, it has to be at a slow rate because there's no suture. We're just moving teeth. But we're also moving the bone because they're little kids. So we have to work at the right rate. And the right rate happens to be a 0.35 mil screw, where you turn half a turn of 45 degrees and it gets you 0.35 mils every 8 days. If you don't use that screw, you'll get ulcers.